Thank you. Thank you, Shira, for this nice presentation, and thank you for inviting me to this excellent meeting. So my presentation is about the management of lean patients with non-alcoholic fatty liver disease, which actually I'd like to call them lean patient with non-alcoholic fatty liver disease instead of lean NASH, because, I mean, NASH is not lean or fat, NASH is NASH, but patients could be lean or fat. That is an interesting differences. So starting with the definition, so we know that there are some differences between Asian population and the Caucasian population, so that the cutoff for defining lean patient with NASH is 25 kilogram for the Caucasian population and 23 for Asians. In many of literature papers, we find Asian population with a BMI minor than 25, but these belong to the category of a non-obese patient with non-alcoholic fatty liver disease instead of lean patient with non-alcoholic fatty liver disease. And this is important because these Asian patients classified as non-obese could be the analog of overweight patients in our population. So sometimes literature results could be misleading when considering the Asian population with a BMI that is under 25. So this is some major literature studies, including patients with non-alcoholic fatty liver disease and BMI under 23 or 25. They're mixed here in this review. And as we can see, most of them are from Asia, and one from Belgium, one from the USA, and from Greece, Australia, and Spain, including the lean patient with non-alcoholic fatty liver disease for the Caucasian cohort, but the major studies done in literature, including the characteristics, cross-sectional characteristics of patients with non-alcoholic fatty liver disease and a BMI minor than 25, were done in the Asian populations. But in these days, there are an effort to analyze also these patients in our Caucasian population. But how can a lean subject get non-alcoholic fatty liver disease? So this is an important question. Before going through, I'd like to underline that we have different kind of patients with non-alcoholic fatty liver disease across the continent. I had the possibility to see patients in both Italy and the United Kingdom, and I can say that patients are different. Obese patients in the United Kingdom are in a higher percentage rather than Italian patients with non-alcoholic fatty liver disease, and morbid obese patients with non-alcoholic fatty liver disease are in a higher number, of course, in the northern countries rather than in the southern Europe in general. There are many reasons why non-alcoholic fatty liver disease can affect patients who are lean. There are some environmental components. There are some, of course, congenital or acquired disturbs. There are some endocrine disorders. There are the category of the metabolically obese normal weight subjects that we should take into account. Patients who are perfectly lean but take some drugs related to different diseases. And of course, other conditions affecting lean patients that actually end with accumulation of fat in the liver. Because what matters for us today is the accumulation of fat in the liver, despite these patients are obese or not obese, because we have to deal with that even in our everyday life in our clinics. So let's start with the first category of these patients. So the patients who are lean for environmental causes, both for alcoholic or non-alcoholic fatty liver disease, but we would like now to concentrate for non-alcoholic fatty liver disease. But I'd like to include alcoholic because the history of the patient sometimes could be misleading, and we don't have today a tool that can objectively tell us if the amount of alcohol that our patient drinks. So we need to rely on their history and what they say, asking families, but this is all what we have today. So, but I mean, we have also some hints from the analysis, from blood analysis, from a lot of things, but we don't have an objective tool that can say, yes, I can exclude the alcohol here. Let's start with the low-fat or high-fat diet in our patients. We need to know that in this first study, more than 14 years ago in Finland, this group actually wanted to understand liver fat accumulation in those patients based on their diet. So if the diet can increase or reduce or change liver fat accumulation in these patients, despite the fact they are lean or fat, just, accumulation of liver fat in those patients. And so they have 10 normal subjects. They treated them with 2 weeks of different type of diet. Was this diet a high-fat diet or normal diet? And they measured then liver fat and fasting serum insulin. So in the high-fat diet, there was an increase of liver fat by 35% in these patients, so just only based of 2 weeks of diet, just what they eat. And a decrease of the change of minor 21% in patients that have a low-fat diet. But the interesting thing is also that the fasting serum insulin increased in patients with high-fat diet by 32%, and the low-fat diet decreased by 20% from the baseline. So this study underlined how patients, the liver fat accumulation in our patients can just change in a short period of what we eat, and so we can have some consequences of our liver without an increase in percentage of our BMI. Another thing that we have to take into account when we consider diet in our patients are, of course, soft drinks and fructose accumulation and the fructose intake. We had this morning's talk about the fructose in our patients. There are many studies in literature about the fructose. This study, I think it was outstanding about the number of soft drinks drank by patients. Even this patient had metabolic syndromes features or not metabolic syndrome features, and compared with controls. So we can actually see how controls in this cohort had a lower number of soft drinks, and patients with or without metabolic syndrome features but with fatty liver had a significantly higher percentage of soft drink intake. And these soft drinks are actually independent of the energy intake of our patients. So if you have the same energy intake in our patients or in these subjects, so the difference is significant in the intake of soft drinks with the equal amount of energy intake. And the primary dietary sources for fructose in these kind of patients are, of course, corn syrup and sucrose, which is commonly used for sweetened beverages. And we have spoken this morning about how, politics could be important here to main actions in decreasing this fashion. And the intake of soft drinks is 5-fold in NAFLD subject comparing controls according to this study. And as we say, the consumption of soft drinks can increase the prevalence of non-alcoholic fatty liver disease independent of the metabolic syndrome and independent, I say, from the BMI in this study at least, but in general in our patients. But fructose is not only important for the fat accumulation, but also for histology of non-alcoholic fatty liver disease. For example, in this study in hepatology in 210, showed that in both young patient and older patient, fibrosis were significantly higher percentage in patient with major than 7 soft drinks a day in this population. Also, steatosis in the older population was higher in patients with major than 7 servings drink a day. This is how fructose, just a quick review about how fructose can affect the fat accumulation in our liver, so because it affects the de novo lipogenesis, and This de novo lipogenesis can increase the amount of saturated fatty acids, which induce insulin resistance, induce inflammation, and also from new studies, we know that they alter the microbiome, and this alteration of microbiome also affect non-alcoholic fatty liver disease. So beyond that, fructose, beyond our liver fat content of our diet, we have also to look at two types of patients, which are the metabolic obese normal weight subjects and also some congenital diseases that may affect patients with a lower BMI and affect the amount of fat in our liver. So we know from literature that sometimes BMI is a poor marker of insulin sensitivity, and insulin sensitivity is a trigger of, the lack of insulin sensitivity is a trigger of non-alcoholic fatty liver disease. If we analyze the whole body insulin sensitivity and BMI, we can look from this curve that, the higher the body mass index goes, the lower we have from the whole body insulin sensitivity. But we have some outliers here that you can say. So we have some of the top that have high insulin sensitivity, but also BMI that is higher than 30, which are obese. And another point here that metabolically obese, but normal weight, because they have a lower insulin sensitivity, but also a lower BMI. So this category of patients we have to deal with. Probably the percentage of these patients are different, as I said, across the country, but they present to our attention in our everyday clinic. So, what's the differences between these two kind of populations? So the metabolically healthy obese, metabolically healthy obese in a liver fashion way, because I can say that obese is healthy, they have normal insulin sensitivity, low visceral adiposity. So because, they are obese, but sometimes the amount of subcutaneous fat can exceed the visceral fat, or fat accumulation in other parts can exceed the visceral adiposity, and no liver fat or low liver fat compared to what we expect in this type of patients. And surprisingly, these patients sometimes have high HDL cholesterol and low triglycerides, and we say, okay, that's strange, but it happens. And it happens sometimes. Now we have evidence of these patients because sometimes from bariatric surgery, we have liver biopsy of this patient, and they say, well, there are some steatosis, but no fibrosis, no ballooning, and we are surprised. But these patients can belong to this category of patients, especially at least in Italy or in the southern Europe, that we have bariatric surgery even for patients that they have not diabetes or other comorbidities, so just obese, because our regulation allow that, and so we can find this type of patients. On the other side, we have the metabolically obese normal weight. So this patient normal weight, we have altered insulin sensitivity, so we have normal patient with high insulin levels, high fat mass and low lean body mass, and high visceral adiposity. So for example, the BMI is not so high, but all the lipid is accumulated in their abdomen, high liver fat, and triglyceride are high together with the low HDL cholesterol. They have also high blood pressure and high risk to develop type 2 diabetes mellitus and cardiovascular disease. This actually is the main risk of mortality in these patients. So when we look at the follow-up of these patients, so they have, for example, cardiac events in a younger age despite their lower BMI. These studies, there are some studies in literature that actually wanted to investigate what are these risk factors for developing non-alcoholic fatty liver disease in these subjects, so why these are non-alcoholic fatty liver disease, but there are some agreements in these studies. Of course, the HOMA-IR index is one of the major triggers of non-alcoholic fatty liver disease, despite the BMI, so even if they are lean. And another fact that we have to take into account are triglyceride levels in these patients. And all the studies underline a higher triglyceride levels in these patients despite of their BMI. let's move to some congenital and acquired lipodystrophy. It's not so common. It's a rare disease. But we need, especially when we have a patient with altered liver enzymes, with steatosis, and with no subcutaneous fat, and almost all visceral fat, and distribution of fat that for us is abnormal, to take into account this lipodystrophy that can also be consequence of long-term HIV retroviral therapy. So, and sometimes we have some referrals for our infectious disease colleagues for this patient with non-alcoholic fatty liver disease or liver fat, and we have to take into account this acquired lipodystrophy in this case, which is what we see here, because I mean the congenital sometimes we don't see in our clinics. Maybe a pediatrician can say it, but we don't. Genetics. Genetics is some very interesting point for our patients, because sometimes our patient, they don't have all the things that I have shown before, but they have liver fat, they have insulin resistance, and we don't have an explanation for that. Just to summarize some genetic modifiers in non-alcoholic fatty liver disease that we know very well, like the PNPLA3 gene, which is associated with the accumulation of liver fat in the liver, of course, fat in the liver, and the triglyceride levels, the TM6SF2, the MBOT, which is associated to the alcoholic and non-alcoholic fatty liver disease severity, and recently the HSD70B13, which is I think one of the few or the only one associated with the protection from non-alcoholic fatty liver disease, because other things, other genes are always associated with an increased risk of non-alcoholic fatty liver disease. Of course, we need to look for these variants in our patients, because sometimes they can give us a hint of what's going on or what could going on in the future. We don't have an answer until today if these genes are involved in the development of non-alcoholic fatty liver disease in patients with a BMI minor than 25. Some studies from literature have compared patients with liver fat due to obesity and patients with a normal distribution of BMI but with the PNPLA3 variant. I think this is one of the most outstanding. This was done in Finland as well, with 82 volunteers divided according to their BMI and their PNPLA3 genotype, and they wanted to understand the liver fat inflammation, adipose tissue inflammation in these categories of patient, whether you have this inflammation in patient with liver fat due to obesity only or also for PNPLA3. And they discovered in this study that the gene expression of adipose tissue inflammation were mostly related or significantly related to patients with liver fat due to obesity, but not due to PNPLA3. And that actually is a good point, because we need to know what's the trigger for PNPLA3 in the development of liver fat in these patients, and probably with the progression of the disease, despite of the BMI in this case, because some of these patients were not obese, but they have liver fat. Another familiar condition is the familial hypobeta-lipoproteinemia, FHBL, and these patients, it's also a rare condition, but we need to take it into account when we consider patients with non-alcoholic fatty liver disease and a BMI minor than 25 or 23 if they're Asian. And the characteristics of these patients that they have an ApoB less than the 5th percentile and a low LDL cholesterol. And this disease is associated to decreased capacity of export triglyceride outside the liver. So you have a great amount of triglyceride in the liver, and this is reflected into liver fat. Is this dangerous or not? Some reports from literature actually they are controversial reports, because some reports explain and show that patients had eventually cirrhosis and hepatocellular carcinoma, so it's dangerous. and also that it's reportedly in literature that a patient with the ApoB67 mutation died from rapidly progressive hepatocellular carcinoma. So this is another thing you have to take into account. But another study in gastroenterology in 2010 showed that the accumulation of triglycerides per se is not a trigger of hepatic insulin resistance, but it's a marker or a consequence of insulin resistance due to other causes. So the differences was not significant between patient with FHBL and normal triglycerides rather than non-alcoholic fatty liver disease. So we have controversial results here, but it's something that we need to look for when we have patients, lean patients with liver fat accumulations. Lysosomal storage disease is another interesting point. Again, here there is an overlap between us and pediatricians, but because we have two types of onset, early childhood and late adulthood, we probably see the second one when we see it, because sometimes, it's very rare, so for us it's very difficult to have that in our clinical practice. But we also, again, when we struggle in finding why this patient have liver fat and why this patient have altered liver enzyme, we need also to take into account this rare condition. We have some hints about this disease. For example, this is a case of a 5-year-old boy, but it's the same for adults. The histological mark is the microvesicular steatosis, which is more expressed than microvesicular steatosis of non-alcoholic fatty liver disease in adults. And this is the gold standard for diagnosis, the dried blood sample and the lysosomal acid lipase activity dose in this lab. It's a tricking exam. It's not so easy to, at least initially we have to send this dry blood sample in Hamilton lab, so that's what we do. And there's also a genetic test for this mutation, but I think the diagnosis should be the combination of both of them. We have a treatment here, the sebilipase therapy. It showed to have good results in normalizing AST/ALT, but I won't go into deep in that, just to give you a hint about that. Just very, very fast, there are some endocrine disorders that we need to look for in our patients, and some drugs from the history, because if we know that, treating the cause is very important in treating also the fat accumulation in our patients. But some recent studies, this one from our group and collaboration with Jacob George from Australia in hepatology, gave actually an important role for the gut microbiota in lean patients. But we know that lean patients may have an alteration in the microbiome, but this study included also a treatment in the animal model, reversing microbiome in lean mice. And when you reverse the microbiome in lean mice, these mice actually reversed also non-alcoholic fatty liver disease. And this study underlined a role for bile acids in the development of non-alcoholic fatty liver disease in patients who are lean, but this also needs to be confirmed in further studies. So this is a summary of what are the main causes of non-alcoholic fatty liver disease in patients who are lean. But saying all that, how to manage lean subject diagnosed with non-alcoholic fatty liver disease? Is this a condition we should worry about? Is benign or not? We need to answer this question some longitudinal studies, and literature lack of these longitudinal studies on lean non-alcoholic fatty liver disease. We have from the US and from enhanced cohort some long-term results about patients who were diagnosed with non-alcoholic fatty liver disease by ultrasound. So, this is the main bias of the studies. And in Lean NAFLD, individually have relatively less components of metabolic syndrome in the follow-up, and non-alcoholic fatty liver disease was actually individualized in 7.4% of this patient by ultrasound at baseline. So, but on the long term, they have not different any, I mean, their metabolic syndrome components were lower than the obese patient diagnosed at baseline. Also, in another study in Belgium, confirmed the fact that NAFLD less likely to be associated with metabolic syndrome, but this patient showed, nevertheless, some components of insulin resistance. But what about mortality? So we have some studies about that, so that mortality of the overall mortality of patients, lean patient with or without non-alcoholic metabolic syndrome, could be worse or better or the same. So if these patients, the red line, are without metabolic syndrome, so if they are lean, their mortality is less rather than patients who have the metabolic syndrome. It seems obvious, but I mean, it's worth it to look for it. Longitudinal studies, we have these three published in literature. One is in the Asian population, one is in an abstract form, never published, and the third one was 2018 from Hagström. The first one, after a median follow-up of 49 months, showed that our lean patient have hypertriglyceridemia and higher creatinine. The other one, it's the CRUISE. The 2014 is a very interesting study involving all ethnicities and Australia, United States, and Europe. And this study was the only one which showed that lean subjects have a higher overall mortality rather than the obese subject, but it was highly influenced by ethnicity of patients. So Asian patients and non-white patients were the most affected. On the other hand, the Danish study of Hagström underlined that the lean patient was a higher risk for development of severe liver disease compared to patients with non-alcoholic fatty liver disease and higher BMI. So we need, we can go deeper into these studies. So the first one is the one I've talked about before, the multi-center study from different centers in Australia, United States, and Europe. 1,343 patients followed up for 11 years. And as you can see here from these curves, so the mortality for non-lean, non-alcoholic fatty liver disease was better than the patient who are lean. But again, this was influenced by the ethnicities, because it was including all ethnicities and non-white or Asians. Actually, they have more higher risk than a Caucasian population. But this was the study from led by our center with 1,186 Caucasian patients from Europe, all Caucasians. And the lean patients were 18.4%. This is interesting because this study was actually including patients from Southern Europe and Northern Europe, and the lean patients were only in the Southern Europe cohort. So a patient from the UK, we don't have patient with a BMI minor than 25. I don't know because they don't exist, people with but I mean, or because I mean, they have to prioritize the patient in their clinics. So, of course, morbid obese patients have priority to be seen in tertiary centers. Lean patients here have demonstrated a progression to decompensated cirrhosis, although the survival was worse in obese patients also in this cohort. So, to conclude, we need to know that lean patients with non-alcoholic fatty liver disease should be screened for the presence of insulin resistance, genetic variants, and endocrine disorders. So this is the three important points I'd like to underline as take-home messages for our lean patients. Pathophysiological mechanisms are not totally understood, may include dysfunctional adipose tissue, altered body composition, genetic mutations, epigenetic changes, and eventually an alteration in gut microbiota. And some hints from the studies in literature underline that lean NAFLD patient can develop all spectrum of liver damage, although their mortality is less than the obese patient, but they can develop all the spectrum of liver disease, so we need to take care of them. And so, I mean, it's clear that it's not a benign disease. What we can provide them, the only recommendation that we have here is the adoption of a healthy lifestyle. We don't have drugs unless we want to address the insulin sensitivity in this patient. That I think it's worth it to do that. So this was my presentation, and thank you very much for your attention.
Thank you very much, Ramy.